That's my case. That's my case. That's my case. That one usually is what we see.
All righty. I'd like to call the May 16th, 2023 meeting of the Health and Human Services Committee to order. We have two of our illustrious commissioners here. We can't pass our motion in regards to the minutes, but we can certainly start our meeting, and as our other colleagues will join us, they'll have to just catch up with us. So my name's Arthur Griffin. I chair the Health and Human Services Committee of the Mecklenburg County Board of County Commission. And I'll turn to my colleague to introduce herself.
Good afternoon, I'm Laura Meyer and I represent District 5.
Thank you so much. As we wait to approve our minutes, Mr. Trotman, I will call on you to introduce yourself and the staff members that are present at this point.
All right, good afternoon, Anthony Trotman, Deputy County Manager.
Good afternoon, Stacy Lowry, Director of Community Support Services.
Hi, Renard Washington, Public Health Director.
Taya Cruz, Assistant to Deputy Manager Trotman.
Robert Nesbitt, Chief of Staff for Consolidated Human Services Agency.
Good afternoon, Jacqueline McKnight. I'm the Deputy Director for the Department of Social Services, the Department for Child, Family, and Adult Services.
Good afternoon, Yolanda Griffin, Director for Community Resources.
Thank you all. This is an important topic for us. It's one of the topics as I polled the commissioners early on as chair of the committee. One of the topics that was expressed is what are we doing in terms of access to primary care? And that would be both physical care and mental health. This is a response to that particular request. Keep in mind, one of the other requests that came out from the survey was healthy aging. And that's why we made that follow-up today. And so at some point, not the next meeting, but at some point, we'll talk about healthy aging and we'll get to some clarifications about the various roles that the county plays or does not play as relates to healthy aging. So my other colleague is here now. So before our presentation, I'd ask her to introduce herself.
Hello. I'm trying to catch my breath. I'm Elaine Powell, Mecklenburg County Commissioner for District 1. And happy to be here safely.
I'm happy for you to be here safely too. Now that we have a majority of our committee members, we can now approve the minutes from our last meeting. So if you have a copy of those minutes before you, if there's such a motion for approval.
Motion to approve.
Second.
Been properly moved in second that we approve the minutes of our last meeting. Is there any discussion? Hearing none, all those in favor say aye.
Aye.
That passes. Our meeting topic today, again, is access to primary health care. It's like our last meeting. Periodically, we hear from the public generally about topics of interest. Infant mortality was the last topic of interest for this committee. We received some pretty good information from Dr. Washington about what's happening. We'll continue to follow that up so that at some point, we'll be able to articulate as a board of county commissioners, something called goals, meaning how do we reduce infant mortality, at least from the preventable deaths. There are some deaths that out of our control, but at least some focus to kind of look at preventable deaths and how we can reduce infant mortality in Mecklenburg County. The topic today, access to primary care, is something I heard a lot about as I traversed this county. Don't know a whole lot about it, but that's why we're having the experts to present that today. And Mr. Trotman, I'm turning over to you to turn it over to Dr. Washington, however you want to proceed with this.
Well, thank you, commissioners. In response to your inquiry and several other board members, and it being a board priority, we have one topic for discussion today, and we wanted to leave enough time for the board to kind of go deeper into this discussion so that we can leave out of here with, all your questions answered as best as we can, and or any additional plans that this committee will want to put forward to the full board.
Thank you, sir. Dr. Washington. And thank you for taking me on a tour of the public health facilities.
You're so very welcome. Anytime.
They're very interesting.
So much of what I'll share this afternoon, good afternoon, everybody, is going to look a little familiar, but this really is, as Deputy County Manager Trotman just said, is meant to set the stage for a discussion about what else we should be doing, what else could we be doing, and what to expect as we move ahead with issues related to access to primary care. So primary care is, as you've heard me talking, has already been mentioned today, is
I can leave too early.
Okay, I can just
There you
use
go.
the computer. Is that you or me?
That's me.
All right, perfect. Thank you. Primary care is a really important part of healthcare overall. It is important as we think about ensuring both the health of individuals, but also of families and people who access primary care are ultimately healthier individuals. It gives us an opportunity for folks to interact and engage with the medical provider on a regular basis. It creates an opportunity for individuals to have a medical home where if and when they have health issues that may emerge, they know where to go, but also it helps to ensure that people are making the best decision, have all the information they need to make the best decisions about living a healthy lifestyle. People who have chronic illnesses, primary care is a gateway to ensure that those issues get diagnosed early, treated as soon as possible, and when possible, redirecting folks on a better lifestyle that may involve pharmaceutical or other options to be able to address whatever those chronic conditions may be. And then lastly, people who have a medical home access primary care routinely are less likely to use the emergency department or hospitals for care, either for urgent care or emergency care, or their conditions are more likely to be managed in the community so they don't have to go to the hospital in crisis mode, for example, when their blood sugars are extremely high. Improving access to primary care specifically remains a high priority for the community. As it's already been stated today, it's a priority for the board of county commissioners. It has been a priority in our community health assessment for the last 2 iterations and will be a priority in the next version of the community health assessment that you'll be seeing in the next several months. In terms of adults in Mecklenburg County with and without primary care, again, this is not going to be new information for you all, but of course, folks who don't have a primary care provider identified are more likely to be younger adults, specifically those who are more likely to be, or at least feel healthier and not have any issues and not prioritize primary care, as well as there's differences by gender, as well as by race, which of course, our Hispanic residents are less likely to have a primary care provider, but they're also much more unlikely to have a health insurance, which of course is a huge barrier for folks who need access to primary care. If you can't afford to pay for it, then of course you're less likely to use it. About 16% of adults in the county overall report not seeing a doctor in 2022 because of costs, meaning that they were not they avoided some kind of care, and this is not specific to primary care, but they avoided care in general because of the costs associated with it. A similar pattern here, if you look at that by demographics, you see this is more likely to be men, those who are Hispanic, again, which is less likely to have insurance access, but also folks who are on the lower end of the socioeconomic status in terms of educational attainment as well as income. Again, all of this is interrelated to individuals' ability to be able to access healthcare insurance, as well as their ability to be able to pay for care. Every year, the health department conducts a behavioral risk factor surveillance survey locally, which is a survey of our residents. We aim to survey about 1,000 residents each year. And the last slide and the slide before are all data that come from that survey. We also ask questions in addition to asking about, have you used primary care recently? Do you have insurance, and information about your socioeconomic status? We ask about some health behaviors, including, have you gone to get the recommended screenings? Have you received certain types of vaccines? And so this is some data from that gives us, again, some indication of opportunity as it relates to individuals' engagement with healthcare. 2 specific areas of concern are related to cancer screenings. And so we do ask about mammograms, colonoscopies, as well as pap smears. And so you can see here that about 1 in 5 of the adults who are over the age of 45, which is the age at which you should recommend it to get your first colonoscopy, have not received at least one of those. And again, similar patterns as it relates to demographics as well as socioeconomic status. And roughly 10% of female residents reported not having a pap smear in the recommended time period. Very similar patterns as you would see if you were to look at the other demographics that I described earlier for folks who are not accessing these services. So what's the point here? I mean, the point basically is there are folks in our community who don't have access to healthcare insurance because either they are not eligible for Medicaid services because they work and make too much money to qualify, and they have an employer who either doesn't offer it, or their employer-sponsored plans are not affordable for the employee. And so the person has to make a decision about keeping that revenue money for their household, or they have to purchase those health insurance plans. And so you see that similar pattern in terms of demographics, because these are the folks who really are falling through the gap in Mecklenburg County, but really in communities across the country. I think it's important to recognize that beyond what I just described, there is an individual component to this. There is some aspects of accessing primary care. There are residents who have access who don't use it. There are a lot of folks who have Medicaid, for example, but still don't have a medical home. Medicaid, when you enroll in Medicaid initially, and my colleague can talk more about this, but those individuals are required to adopt a plan, and the plans are required to have every individual adopt a primary care provider. And so they have a directory, as no different than most of our own insurance plans, where you can go pick one, and Medicaid recipients are required to pick a provider, but they're not required to go visit the provider. And so while they may have a provider of record, it doesn't mean necessarily that they have a medical home that they're attached to and are receiving preventive care that's needed, or other types of care. And that might be there. And so part of our challenge as we think about primary care access, of course, is some of these issues of access that I'm going to get to next, but also the individuals and making sure people are aware of the importance of accessing primary care and then aware of the importance of using it, and also have as easy a time getting to it as possible. And so part of this is definitely about education and awareness among residents in the community. And we have some tactics that look at that. And then the second piece of this, of course, is how easy is it for people to be able to access it? So is it in the communities where they live? Can they afford to pay for it? And do they feel comfortable at the provider that's available to them, which is several layers of access that we don't have great measurement for. And I've talked to Chair Griffin about this before. It would be great to know how happy people are with the quality of care they're receiving. It might be great to know how many appointments are available today, as well as the availability of appointments that for people who have Medicaid. But right now, we're not at a place in our understanding of this issue where we have access to data that can tell us those questions. In other communities that do have a better visibility into some of these issues of appointment availability, Medicaid acceptance, they have commissioned special efforts to be able to either create systems to track that information or to do point in time studies to understand what's happening in the community at that time. And so we don't have a means to be able to tell you today, for example, how many of our providers in the community are accepting Medicaid and have Medicaid rosters that are the proportion of their patients is enough. Like, so I don't know, I can't tell you specifically how many primary care doctors we have and how many of those have an appointment slot for a Medicaid patient. So that is a gap in information for us as we think about telling the whole story of access in the community. I also can't tell you, if I have Medicaid today and I want to find a primary care appointment, can I call, how many providers can I call today and make an appointment with in the next 6 weeks? And so those kinds of studies we have not embarked upon yet in this community, but certainly that is something that could be on the horizon as time moves forward. That being said, we do know that there are a high supply of Medicaid accepting providers in the community, but we have not dug into the details of their availability. This first report that we did was sort of the first step in our work. And we hope that over the next coming years, we're able to dig in deeper to be able to ensure that we are doing that, have a solid understanding of what's happening with access to care here in the community. And this last bucket about appropriateness really speaks to if people are comfortable with the quality of care they're receiving. So are the providers culturally competent? Are the providers delivering care in a way that honors people's identity, personality, and another opportunity for us in terms of what we know. But absence of having that information, we do have several partnerships that help us through our work with AHEC, Charlotte AHEC, which is the Area Health Education Center, to just make the assumption that providers need educational competencies like cultural competency and others. And so that is happening. But again, I can't tell you today the level of, I can't give you data points to point to the quality of the care in that regard. There are some very narrow data points for select sets of providers. For example, the FQHCs, they have quality measures that they're required to publicly report, which I'm not going to talk about today specifically, but I'm happy to share with the commissioners if you want to. It's a publicly available report. If you want to look at it, you can look at their quality measures. But that's a requirement or condition of their federal funds, and it's not consistent across. Like, for example, our healthcare systems don't do that, and neither do the other free and low-cost clinics. So the quality measures that they report are unique to qualified health centers. But the combination of all that I just discussed really sort of equates to why people don't go to primary care or why folks don't have a primary care doctor. And really our work across all of these buckets are really is what's going to help close the gap ultimately. But it is a labor of love to address all these various issues. One data point we do have is the number of primary care providers because of the we're able to actually acquire this information through professional licensure data of understanding how many providers have primary care certification, board certification, and are delivering primary care or actively delivering care in Mecklenburg County. If you take all that number of providers, we do end up actually having a sufficient supply of providers in Mecklenburg County. But I'll go back to my comments on the last slide. I don't know that this is not triangulated with their Medicaid acceptance or if they have patient appointments available and how much it may cost for somebody to go to them. them. So this is just everybody put into one bucket and the total number of supply of providers there. In fact, we are below the target for Healthy People 2030 North Carolina, as well as the federal targets for areas in terms of how many providers you have per resident. So the number of doctors we have in the city is not necessarily, the county is not necessarily a red flag, but it could be if you dig deeper and look at Medicaid acceptance and availability of appointments. Speaking to affordability, specifically around insurance status, this is no surprise to you all, but we have a large number of our residents, particularly about a third of kids who are currently receiving Medicaid. About 6% of kids don't have a insurance provider. And of course, we work to make sure that children who are eligible for Medicaid are enrolled in Medicaid. And we have a number of programs that interact with children who ensure that kids are getting enrolled in Medicaid if they are eligible, to close the gap there. Similarly, we have about 15% of adults who are on Medicaid, adults 19 to 64, but a larger share of those without health insurance, a larger share of those, I'm sorry, I said that incorrectly. 15% of adults don't have insurance, and about 7% of adults have Medicaid. In Mecklenburg County, this is as of 2020, based on the census reports. And so that 15% of adults without insurance are either folks who, again, fall into that coverage gap where they make too much money for Medicaid, but not enough money to afford their own insurance, or they could be potentially self-employed and have opted to pay cash for healthcare and not have an insurance policy. Uninsured rates are higher among younger adults, which of course makes sense. The working age individuals who are more likely to be working in frontline jobs or jobs that are potentially more manual in nature or may not offer coverage options. Big differences between gender and racial ethnicity. And of course, individuals with lower education and income are less likely to have healthcare insurance. You are very familiar with the crescent here in Mecklenburg County, and so those patterns are consistent. If you look at insurance rates by census tract, you can see very clearly the darker blue areas are where insurance rates are the highest. Some of those census tracts are as high as 50% of folks without insurance. And that varies, of course, even further when you look deeper within those census tracts.
Can you just, on that slide, can you describe the coloring better?
Sure. So it's graded from blue to gray, with blue being the highest levels of uninsurance and gray being the least levels of uninsurance. So areas that are lighter gray have more people with insurance, and areas that are teal have more people without insurance. So everything that's blue and green is areas of very high uninsured rates, and everything that is in the darker gray has higher uninsured rates than the average in the county. But they are lower than the areas that are teal. And then the lighter gray areas and the shader gray that's right a little bit darker than that have the highest rates of folks with insurance in the county.
The dark gray has the highest rate?
So from worst to better, worse is teal.
Got
The next worst is the darkest gray.
Okay.
So this one right here.
And then
The worst, better than that is this one, this lighter gray here, and the best is this lighter gray up in your area.
got it. Got it.
Sorry. We typically just use one color and do the grading of it, but the effect here is better if you can see the teal. And I'm sorry, in the report that there's a legend, it got cut off in this figure, so that's why you can't see it. One other issue we wanted to make sure that we, in the report that you guys have all seen and heard me talk about before, is just an assessment of where we are with primary care for people who don't have insurance and people who are on the lower end of the socioeconomic status in the county. And so this map you guys have seen before, but we've gone back in and added the names of the locations so you can actually see who operates those physical locations. And so this includes all of the low-cost primary care sites in the community. And when I say low cost, what I mean is there are providers who either provide care to residents at no cost if they can't afford it, or they provide it to them on a sliding scale of some sort. Or in the case of the hospitals, where they offer a comprehensive financial assistance program for residents And they have support on site at these clinics that help people enroll in those programs. So they don't have to cover the cost of the care they will receive at those locations. So I'll quickly walk through the providers here, and many of which the county directly supports many of these. Up in the north end of the county, you'll see we have just a lone low-cost provider, which is the Lake Norman Community Health Center, which we do support financially through our community service grant program. And so they do receive an allotment annually from the health department, from the county through the health department. Going down, I'm going to go to all the low-cost clinics first, and then I'll go back to the FQHCs. Camino here is obviously, you guys are familiar with Camino, but they are largely a Hispanic serving organization that's connected to a faith-based organization, and they have a community health center and medical center here, which we also support. Rayo and Caring are the only two options that are really in the center city that are providers who offer sort of primary care services, but their primary care, they're not intended to be medical homes. So they really are primary care that's intended to stabilize patients and then get them connected to another primary care provider who's a more long-term option. Neither of those providers currently bill Medicaid for services, for example. And so they're ideal for individuals who are incredibly transient, for example, like our homeless neighbors, or they're also individuals who maybe are in between migration here or someplace else and need to get stabilized and just need to see a doctor or a nurse to get a prescription for their diabetes or something, and then ultimately get them connected to a place where they can receive long-term care. On the east side, we also have Hope Community Clinic, which I think some of you have visited their new site that they just opened. That location tends to also lean into our folks who are migrants to Mecklenburg County from all communities. They have a very robust set of wraparound services at Hope Community Clinic that offers care and support, obviously language translation services, and they have a strong rapport with the refugee migrant community here in Mecklenburg County. And they just opened a new facility. They do partner with Novant Health to deliver some of the care that they deliver. And then in south of town, there is the Matthews Free Medical Clinic, which delivers low-cost primary care as well. More intentionally medical home, but certainly is still has limited capacity relative to some of the larger sites that I'll talk about in just a second. On the FQHC front, we have two FQHC operators currently in Mecklenburg County. That's Charlotte Community Health Center and C.W. Williams Community Health Center. Charlotte Community has two primary locations, one up in University and one on the west side. They also have a number of satellite locations that they operate out of, including they are opening some new satellites, one at the Smith Family Foundation Center, and they are looking to expand further. And we, in fact, the county, thanks to you all, have given them some additional investments through the ARPA funding to actually identify additional satellite sites. And so they are working on construction and all the necessary particulars to be able to establish additional satellites. C.W. Williams currently has their main primary care site. I forget the street. Ben, you'll have to help me.
Old Pineville Road.
Old Pineville Road. Their Wilkinson Boulevard site, which is the one that folks who've been around for a while is probably most familiar with, is not functional at the moment. And so they are intending to demolish that building, as is my understanding, and rebuild another facility at that site. And so I don't know, they were renovating the building and then I think the renovation stopped, and I think they have plans to rebuild a new one. And so I'm not sure what those plans look like, but the county also made sizable investments into C.W. Williams to assist with the capital needed to be able to do those constructions. I don't know the status of that just yet, but I do know that that's the plan to refurbish that site to deliver primary care there off of Wilkinson Boulevard. Lastly, the green boxes you see here are the hospital or health system affiliated primary care sites in the county. These sites are both, if you drive up to them, they're Atrium and Novant Health Centers essentially, but they are enhanced with having the staff on site to assist residents with enrolling in the hospital's financial assistance programs. And so Novant has two Michael Jordan clinics, one in the north end and the one, of course, that's near us on Freedom Drive. And then Novant has a small clinic in the Movement Center as well. And then Atrium has 5 primary care sites across the county: Biddle Point, North Park, Elizabeth, Myers Park, and Archdale, where they are currently delivering primary care services with plans, of course. I believe they both have intentions to continue to create additional sites as needed in areas where we don't have access currently. But overall, we have, I would say, fairly okay coverage across the county in terms of physical locations. I will go back to the point I made earlier about what we know about all primary care providers, the availability of appointments, as well as the time to an appointment, as well as the quality of care. I'm not talking about any of that today. I'm just telling them that to build in there, they have healthcare providers so you can go get care. I don't know how long it's going to take to get it, but I can tell you that it's there. And I say that jokingly, but seriously, that is part of the equation that we're working. And Ben is here today because he's been working very closely with all of these providers to make sure, particularly the ones that we financially support as a county, that we are holding them accountable to both the quality of care they're delivering, but also that their performance and outcomes are tied to the investments that we're making as an organization into these organizations to deliver primary care. I will say very transparently to this point, we, public health and others, have not done the best job of quantifying the impact of these investments in terms of lives and number of visits and the amount of care. And so we have completely overhauled our reporting system for these providers that we financially support to ensure that I can come back to you guys in the next year and say, this is what you got for your money. And this is what we can do in terms of doing more with these entities. We did increase our investments, and I'm going to get to this in a second, with all the ones we directly support. And tied to those increases are improved performance reporting and outcome reporting. And so that is something that we've been working on for the last year and baking into their contracts so that we can ensure that we're measuring outcomes. And this is, we're maximizing the return on investment that we're getting for the money that we invest in these agencies. We do not financially support the hospital affiliated systems in any way. It is a part of their community benefit, and their financial assistance programs are globally a part of the departments, both of the health systems, community health initiatives. Together, we surveyed all of these entities last year, and so this number may have changed some, but together they have the capacity to serve about 40,000 people on an annual basis. And so if you go back to the number of people who don't have insurance in the county, both adults and children, and all of these providers, for the most part, with the exception of Caring, will see patients that have and don't have insurance, which they need to do to be able to keep their doors open and lights on. And some patients that can pay and some patients that don't. And so this 42,000 includes the patients who are Medicaid covered, Medicare covered, and uninsured. And so the availability of spots for people who don't have insurance is not 42,000. This is just the number of people that they have the capacity to serve. And so if you look at the number of folks without insurance and this gap, we still have a pretty wide gap in terms of availability of places for folks to go to get primary care that's not, that they don't have to pay, they can pay where they can afford, essentially. I talked to this with you guys, but I did want to note that there was a lot of discussion with the board about creating new FQHCs. It is a fairly complicated process. It's not as simple as just creating a new one. And the federal partners, HRSA, has not made new application opportunities available to us at the moment. It doesn't restrict the existing FQHCs from opening satellite sites, which is the strategy that our FQHCs is taking with opening these additional sites. The trick is they don't get additional money from the feds for opening those additional sites. And so those sites are still tied to their initial FQHC application. And so they're not getting that additional $750,000 grant on an annual basis that would make that site sort of standalone with support from the feds. And so they are still basically creating new sites with no real money to go along with it. But they do get access to the additional benefits, the 340B prescription drug program, as well as the enhanced reimbursement rate for people who have Medicare and Medicaid. And so that the new sites do still create business, but it is, they're not getting that federal grant to help support their base infrastructure that would be needed. There are a lot of rules, as I mentioned, with FQHCs and lots of reporting requirements. And so many of our low-cost clinics, so someone might ask, why aren't the low-cost clinics federally qualified health centers? a lot of contingencies that come along with being a FQHC, that if I am a Matthews Free Clinic, for example, or Caring, I may choose as an organization not to pursue that because of the additional responsibilities that come along with it. They have to assure or deliver comprehensive care that includes behavioral health services and meet certain standards in terms of being a medical home, that again, some of these entities don't have the infrastructure to support at this point. And this is where we, in our conversations, and again, Ben and Dr. Coyle, who could be with us today, are working alongside them to understand how we can better support them as they look to grow and establish stronger infrastructure. However, that is not, it's not an overnight process. And they've just recently conducted site visits with all of them over the last couple of months. And went on site to see what was going on, listen to them, and hear what more we as a county can be doing to support them. And I will tell you, overwhelmingly, we as I mentioned earlier, we've increased our investments in them over the last 2 years with the support of the board. And are excited that we think we're going to have some positive results to share at the end of this fiscal year about what those increased investments were able to do in terms of increasing access. But everybody's got to grow at a pace that they can keep up with, which is one of the biggest challenges. You guys have heard us all talk about our challenges with clinical staffing, and our FQHCs and low-cost clinics are experiencing the exact same challenges. And so when it comes to hiring staff and being able to pay them competitive salaries, both nurses and otherwise, they really are struggling even more so than we are, because you think about their ability to stay competitive, and the market is difficult because they're competing as well against the HMs and the Novants, and others who are paying high dollar for clinical staffing. So everybody's sort of in the same boat. And so money is not the only answer here. And so the intention of our site visits, one is to, of course, orient Dr. Coyle, but also who's our new medical director, in case everybody doesn't remember her, but to also give us an opportunity to continue to engage with them, to hear what we might do to better support them as they look to build infrastructure. But it is not just giving them more money. It really is a matter of trying to understand some of the nuances of their business operations that we might be able to help support. And we're still learning, and I don't have a recommendation today. I just want you guys to be aware that that's on our radar as we're communicating with them. All right, as we've already talked before, the report had 4 big recommendations. And you guys know some of the activity that we've been engaging in to improve access to care in the community. The last time I talked to you guys about it, I asked you to advocate for Medicaid expansion, and that I think we might get it, but there's still it's not across the finish line just yet. So I think we don't have a budget yet, so it's tied to us having a budget. So I think there's still need to advocate, but I did change this to implement because that is our next phase. And as you all know, Yolanda and her team are working aggressively to make a plan for what implementation looks like here in Mecklenburg, so that there isn't a coverage gap for folks and that there's not a delay for people getting coverage. There will probably be one in every community that in North Carolina, because it's just a lot of people and a lot of work. But the reality is that that's the next big hurdle for us. And it is important for us to ensure that we have providers ready to care for these people when that occurs. So let me see, I'll skip ahead now. We expect that about 65,000 residents will be eligible with the expanded Medicaid eligibility criteria, which means that 65,000 folks need to be engaged and told that they are eligible. They've got to have the eligibility determined. They've got to, for this particular purpose in primary care access, they've got to get a primary care provider and get an appointment scheduled. And so that whole life cycle, the front side really is what our partners in DSR is going to be working on. And then simultaneously, we're working to make sure that the system is ready to receive those patients once they have care. And making sure that we have community health workers available to assist as folks are navigating the system. Getting an insurance card for some people is like getting a driver's license, right? But if you've not had one in recent time, it is not, you need instructions to go along with it. And so making sure that support is provided on the community front to be able to navigate the system is another important part of this equation. So. As I've already alluded to a couple of times, we did increase our investments overall by about 37%. This does not include the ARPA investments that are term limited. These are our recurring investments in primary care. And so I'll look forward again to sharing with you guys what happens at the end of this fiscal year in terms of what this 30% increase is realized in terms of impact to patients' lives. We do expect to serve about 11,000 people this year with those funds in terms of primary care services. And we are continuing discussions with a number of FQHC's providers, in addition to talking with the existing providers. As I just mentioned, Dr. Cole and Ben have been going around talking to our own providers who are here today about their capacity to expand so that we can make recommendations to the board about additional opportunities with those providers, but also talking to new providers. And we've talked to at least a couple in the last several months about their capacity to do more for Mecklenburg County residents and are look forward to continue those discussions and hopefully solidify some plans in the short order to be able to expand even further as time moves ahead. As I've alluded to twice, we are working as well to raise awareness of the importance of primary care. Our population health division, which Dr. Kimberly Scott, who just walked in, is leading, has a lot of efforts on the ground in the community to connect residents to things that help them live a healthier life and to provide both health education and awareness through a number of our initiatives. One in particular is the Community Health Worker Initiative, which is, again, lay health workers in communities who go around or stationed in community sites to help residents navigate the healthcare system and get connected to resources that are available to them. And so, again, I imagine at some point in the near future, we'll talk more about the Community Health Worker Initiative. We are, I would say, about 1.5 years into without a 2-year pilot of sorts that I hope we'll have more data to share with you all as we wrap up the next contract year with the 2 healthcare systems that we have those community health workers based in. We also have a long-term collaborative called MedLink of Mecklenburg that is currently chaired and co-chaired by some of the leaders from those community health clinics. And that is really meant to be a convening of all of these low-cost providers to help talk about what work they're doing, what needs they have. And so we're really working to try to more intentionally empower them to lead in this space from a community perspective. And so Ben and Carrie Birch, who is our director of OIS for the health department, do participate in MedLink. And again, we're working with them honestly, I would just say during COVID, things fell apart a little bit. And so we've got to refresh them and get them back into the spirit of this work from a togetherness perspective. You know, in COVID, everybody had to go run. And for them, at least, they had to just keep their operations alive. And so now getting them back to this collaborative is high priority for us. And so just things like getting their website overhauled and brochures up to date and their sort of agenda as a collaborative together are issues that we're tackling with them as a group. And lastly, I'll close as I have done with this presentation multiple times and just say this is not a county issue exclusively. There are a lot of people who have a role and are benefactors of primary care delivery in Mecklenburg County. And so there is opportunities for both our healthcare systems, our payers, those providers I talked about, and everybody to share the message of the importance of this issue, but also to help us as we think about how to strategically address it in Mecklenburg County. That's what I have prepared and look forward to the discussion.
Well, thank you very much. As usual, you provide a very clear presentation in terms of what we know and what we don't know. And that certainly gives us an opportunity to chime in from a policy perspective with regard to this important issue. We have time for several 3- and 4-minute rounds, but I just wanted to ask one question and then I'll look to my colleagues for their questions. 5.5 months, I assume they have 6-month anniversary as a county commissioner. And there are a lot of issues in the human service arena and healthcare, et cetera. And in government and politics, in additional issues, I like to try to always put an analytical map, some rigor on those issues to kind of see, okay, where are we? Where do we want to go? And what progress are we making towards our goal or our destination? And so even with this particular issue, you made some comments initially about not really knowing where the gap. So Charlotte has been utilizing the Urban Institute and other contractual resources, what are we doing to try to figure out what is the gap?
Sure. So,
And do we need to do something as county commissioners in terms of resources to even have a process to give us a response to what is the gap?
yeah, so first and foremost, we started this report 2.5 years ago to establish a baseline of what I would say the lowest hanging fruit in understanding the nature of primary care. Up until that point, there had not been any formal reporting on primary care access in Mecklenburg County. We reported on insurance status and inside of other reports, but there wasn't a dedicated focus on this issue of primary care access. And so for us, this was, let's take what we know and what's available to us and consolidate that into one document that can sort of articulate where we are today as a means of really springboarding this issue as a priority for us as a department, but also then as a step one to step two is what else do we need to know? What don't we know, right? And what are the gaps in what we know? And then how can we get there? We have not to date engaged with any provider specifically or vendor or Urban Institute or UNC Charlotte or anybody else to assist us in this work. This has been done wholly by the staff at the health department. We did engage one consultant to help us with the interviews of the primary care providers in the community, but that was an individual consultant. It wasn't meant to be, she didn't write the whole of the report. And so it is definitely a next step for us to commission more additional analytics on this work. But it's in queue basically for a few other things that are also we need to establish a baseline on, for example, like maternal and infant health issues. We certainly don't have this version. We don't have one of these for maternal and infant health. So we need to get that done too. So it's in queue, but it's not something that we have teed up for a time. Like I can say, we're expecting to do that next year.
But as a committee, if we wanted to make recommendations to our full board,
Sure.
It may be too late because the budget's come out on Thursday, but in terms of a recommendation for what resources would be necessary to have an answer to some of the gap. For example, I fully don't know, but I do have a copy of the MEC playbook that talks about parks and what you have and what you don't have. The city has a report on affordable housing, how many units they need, how many units they don't have. I mean, everybody has certain little reports that report certain gaps in services.
Yes. Okay.
But in terms of maternal, maternal birth rates, health rates, death rates and stuff like that, and access to personal primary care, we don't have that. So it would be nice to have the money to hire the experts to kind of give us a roadmap like these other things. So each year we can kind of chip away at that gap.
Yeah, so two things, and I get exactly what you're asking now. So part of the reason why Ben has overhauled the reporting for our existing partners is that we weren't even able to say to a place how many people are we paying for with the amount of money that we're investing into primary care access. And so our stepwise has been, let's fix this structurally so that we can actually report the return on the investment for what we have and what we're actually paying for. Because we had amounts and we had what the service was, but we didn't have, this is paying for 5,000 people, right? Like I couldn't tell you that in a definitive way. And so that overhaul has happened this year and we expect to be there. The second thing in terms of kind of a playbook and thinking about strategy around this, MedLink is certainly the revitalizing MedLink is what we're working. And we don't need money to do this. We need time, resources, and people resources, and basically time to convene these folks to get them to focus on it. But we also are having a design day in June, which is an effort to assist us. So our community health assessment is finishing right now. One of the 4 top priorities is access to care. And so as a part of the design day, which Dr. Scott's here, that will be in June, really is about how do we convene the collective of people in Mecklenburg County who have the both power, resources, and interest in addressing the 4 top issues, access to care being one of them. How do we start to strategize what we call a community health improvement plan? So what is our playbook around addressing these 4 issues? And so following that, there will be the development of that community health improvement plan that will have a specific strategy around access to care that will take into consideration what the county's doing, but we'll also take in consideration what everybody else is doing, which is what we don't want to do this in isolation, right? Because the county's not ever going to cover primary, well, I shouldn't say that. The county probably shouldn't commit to covering primary care for everybody. And there's a lot of
I
accountability.
can say that.
Yes, but there, so we need to ensure that we're also putting everybody on the hook for this. And so
Right.
that's part of the motivation behind Design Day that's happening in June. And you guys will be hearing a lot more about the outputs from that and the plans that come attached to it. But the last thing I'll say is the overhaul that Ben's been doing with the vendors we support is so that I can actually come to you guys and say, okay, last year we were able to support 11,000 lives. I think a reasonable, and we know from the primary care providers, they can support an additional 2,000 lives next year, right? So if we give them, $1 million, this will help us support primary care services for an additional 2,000 people. They have the staffing and the infrastructure and the capacity to care for them. What I don't want to do is to just throw money at them and no care happens because they can't do it. They don't have any nurses, they don't have any doctors, which is a real struggle for them. And so we're trying to be as intentional as possible by physically seeing them, knowing what they can do and resourcing them appropriately as they can tolerate the resource.
Commissioner, I want to just address something that Dr. Washington said about the overhaul that Ben is doing. So many of these contracts came in as community service grants. And the budget management office was managing these contracts. And so there were specific pay points that they were paying them based off of the scope of work. And then after the 3 years, they went to the department as a vendor contract. And all of these performance metrics that Dr. Washington is talking about were not in there. And so here, public health, here's like 4 or 5 different contracts. Now you guys manage them. And so it definitely has taken some time out of COVID because it wasn't the focus of the department while we were dealing with COVID to kind of deal with some of these issues. But the contracts were kind of going over there like right during and after COVID. So that's why we are behind in performance metrics.
Well, I certainly appreciate that. I don't want to hog up. I've got my 3 minutes worth on this first round. I want to see if my colleagues have any questions of me at this point. I know I have others, but Elaine,
Go ahead.
Laura. Okay, Elaine, Laura, Dr. Lee.
Okay,
Okay,
I'll just start with the biggest one. So Commissioner Griffin and I were in a meeting this morning about the difficulty of staffing and how whether it's nonprofit or profit,
Or government.
no matter who the entity is. No, I don't think it's government. Profitability is the goal, not patient care. And so what happens when you have these giants, like, page 16, these health systems that are so profitable, really like putting a lot of the burden on us to provide primary care instead of them providing it. And well, you said that we're not investing in the hospital-owned sites, but we just voted on a contract where Atrium asked for $148,000 for us to pay to Biddle Point for dental. And the board supported that, and I'm thinking that's an investment.
That's a lease. So we've had a long-term arrangement and predates me and probably most people in this room, but our dental facility, which is a county the county delivers the services, the county, any revenue over our costs go back to the county, which go back to the residents. Ultimately, all of that happens in that facility. That's not ours. And so no different than any other building that we lease in the county, that Atrium just owns the facility. And so they're our landlord. But that is not, that is a lease agreement similar to that. And I will say that agreement is actually to benefit of the county and to our residents in a very dramatic way. And so I would be very careful about the how we frame what that lease agreement is, because as a result of that lease, we also have free access to their operatory where we do dental operations on those kids. And we don't own an operatory of our own, and we don't pay them to use their operatory. And so our kids are able to get operations they need, sedation that they need, at no cost to the county because we use their operatory to deliver that care. We do pay for the lease for the actual clinic, which I welcome you guys to come visit. But we do, that is a lease agreement for the space that we take up there. And that comes with the building services, the lights, the water, the security of the building, the parking, all those things are essential to operate that facility. And it's a long-term agreement.
So I'm glad to know that Ben is involved and doing an overhaul. Because it's shocking to think that any public dollars are spent without understanding where they went.
Sure.
And I know code was hard. So, but it's hard to imagine that any contract was ever written.
So I want to be
Well-
fair. I want to be fair to my other colleagues. It's not that there was no reporting, but the level of reporting that we are asking for gets beyond the fact that somebody received care. I would like to know more about the quality of care. I would like to know more about like who the people are that receive care, so that I can ensure that we are targeting the limited resources that we have to the people who are most needed, and that the care is being delivered in a way that is honoring the intention here is that people have access to quality care. So it's not that we didn't have performance measures at all. You guys are asking me a lot of questions about it and have those answers. Other than we served 4,000 people, we've got to have the kinds of quality metrics that we can report back, and it is what our residents deserve, right? I mean, if you want to be able to talk about delivering care to people, you should be able to say more than I gave you something. You should be able to talk about the quality, the types of services they need, and that helps us too. Like if everybody's coming for diabetes care, that information helps us understand that maybe our population health program needs to be thinking differently or targeting specifically diabetes care management in the community. And so it just provides more insights, not that it was nothing there before. So sorry if I gave that impression.
It's okay. Like there's so many questions, but Commissioner Griffin and I went to Cabarrus County to look at a federal program. And because so many people from Mecklenburg are going there because they're not satisfied. And so like all of your metrics matter.
So I would also, satisfaction, it may be one factor there, but also I think geography is another important
For
factor.
sure.
And same thing with Cabarrus Health Alliance. We have people who go there because simply it's the most convenient option for them. And so that is an acknowledgement that we are well aware of, but have been working to get a handle on Mecklenburg County to start. But we recognize that our geographical boundaries are artificial for most of our residents. And so there are people who receive care in all of our surrounding counties, just like there are people who come from our surrounding counties to receive care here, which is another important indicator of about, how many people who are getting care at our FQHCs who don't live in Mecklenburg.
And interviewing people, like I was in the ER for an extended amount of time where, I mean, the hallways were lined, but nobody was getting the care they needed. And I thought, if there's so many people that qualify for some kind of intervention, but there was nobody there asking questions because it was so understaffed, there was not even a real nurse. It was just an EMT. Like, it was awful. This is at Presbyterian Hospital. And interviewing people to say, how did you end up here in the ER when if you had care, if it wasn't something unusual, how did you end up here? Because so many people are using the ER as their primary care.
Yeah, so that particularly goes back to, there are two issues here. The first of those issues is individuals avoiding care. And they very well may be avoiding care due to cost or time or knowing where to go to get care, for example, other than the emergency department. But there's certainly an individual component in utilization of the ER. That delaying of care oftentimes results in people getting sicker. And then people don't go into they either can't go to work or like whatever's hurting them is hurting them enough that they're like, I got to get help now. And that is most of the issues that a lot of folks that you probably saw there, had they gone when they had the first signal or had they been going when they didn't feel bad, could have been detected early. For example, people who have diabetes or hypertension often have absolutely no symptoms at all, years until the progression of the disease. And so you can have it and not know it. You may have some mild to moderate issues, but that's what primary care is useful for. And so those folks who are there are likely have waited until that point. Or the other side of that is We have people who are enrolled and have Medicaid, for example, and have not made the time, don't make the time, or don't know where to go. I don't want to make it all personal accountability because there's some system aspects of this for sure. To go to a doctor outside of the healthcare setting, or they work 8 to 7 every day and no other doctor except the hospital is open after 7. And so that's where they opt to go. And so there are a number of factors that drive people to the ER. And of course, it benefits everybody that they don't go there. And the hospitals work alongside us to do that. But that in of itself is another issue and another important reason why having things like community health workers who can help people navigate the system and not in resort to an ER room is so important and are worthwhile investments. The goal is to get the insurance companies to see the same thing so that they pay for those community health workers instead of paying for that ER visit. And that's part of the challenge of our community health worker initiative.
We go to
That's fine.
Commissioner. Well, you got
We'll come back
another.
to you.
Oh, I'll wait. I'll wait.
No, we got another round. We have time to come
So,
back.
so when I'm talking to employees, there are so many employees that make less than 50,000 for the county. And so they make less than $50,000 a year for the county. But so we have so many people in operations that they qualify as low income. What, and I don't think that we're doing a good enough job of promoting the Marathon Health benefit, because I think that could help them.
It's a great benefit. I mean, I go there.
Yeah,
Good.
so,
Excuse my ignorance. You said Marathon Health?
yeah, so if you could explain Marathon
Sure.
Health.
It's the county and healthcare sponsored healthcare provider. So they have a number of locations. The county has a contractual agreement. I should probably Anthony do this, but I can tell you from the consumer perspective, it's my doctor. If I need something urgently or chronic disease management or just my annual checkup, I go there to receive those things, and it comes at no direct cost to the patient. Of course, if it's a more complicated visit, but basic preventive visits like an annual physical or diabetes management or hypertension management, all that stuff, it comes at no cost to county employees.
Yeah, we use it to decrease the cost of the healthcare, to give you more access, more free access. It should have been part of your onboarding process. You know,
It
for
probably
everybody,
was. I had
yes.
about
Yeah,
six-
so it's
I had
so
6
bad.
inches, 6 inches of paper.
We did not get it in onboarding. I called, I asked questions, I went for a tour so I could understand it. And then I ask employees if they know about it, and they say no. And all they know is they get a once a year reminder to go in for, to get some money off of their
Biometrics.
insurance. And so they don't really have an understanding of it. And I think we should do a better job on that because our deductibles are so high. And if
Yeah.
they're making less than 50,000, our very own employees are suffering
Yeah.
to pay their deductible.
There are several emails that go out to all staff, kind of encouraging folks to use Marathon on an annual basis. So it's something that we need to maybe do a little bit more and encourage the directors to share it in their department updates.
That's
You all
the,
get them.
that's the education piece that Dr. Washington spoke to. Let me go
Yeah,
to
thank you.
Commissioner Meyer.
I'm done.
Okay.
Yeah, Commissioner Meyer.
Thank you. I think we can all agree that it's so complicated. I
Yes.
mean, this is so, and I can't believe you can stand up here and try to explain it to us, and you do a great job. And I think a lot of our questions are real similar. And I just need to understand, and it's something I know I've talked to you about, and I still don't quite understand. It, if you put on that map, all the, or there's so many urgent cares between Atrium and Novant, and then these other providers, I don't even know who they are. If you put dots on it, it'd be covered. They're everywhere. They're like on every corner. But if a patient walked in without insurance to one of those, do they get turned away?
So the challenge with the blessing and curse of urgent care. So urgent cares are intended to divert people from the emergency department so that the most critically ill patients have the beds that are in there. The people who might need to be hospitalized are the folks who should go into an ER, or folks who have trauma. Obviously, if you've got a gunshot wound or a car accident. Urgent cares, however, require payment. And so different from the emergency department, where I can go if something's wrong. Let's say I've had an ache that's been there for 4 years and I decide that all of a sudden it's hurting bad enough that I got to go get somebody to look at it. If I go to the ER, they will see me, they'll register me. I will sit there for 4.5 hours before anybody ever talks to me. And they'll tell me what's wrong with me. And then they'll write me a referral to somebody else outside the hospital for care. But in the patient's mind, they went when it was convenient, they were open and they didn't have to pay a penny. If they go to urgent care, they will register them, they will check them out, they will do the triaging, et cetera. They will ask them to assure payment, and in many cases, they will request the copay before they even see them. And if I don't have $50 to pay the copay, or I feel uncomfortable signing the assurance to pay. Now, people sign assurances to pay at the hospital, but everybody just knows you can go to the hospital and get care and leave. Different at urgent cares because there is more of a financial component to those. And so that is up to those urgent care facilities to how they manage that. Some are better than others. I will tell you the hospital ones, I have generally heard positive things about. There's not this forced cash payment before you're seen by somebody. They all check you to make sure you don't have a life-threatening illness, like they'll make sure you don't have a heart attack. If you say certain trigger words, they will get you to the back immediately without any payment discussion. And some people know that, so they'll do it. But so that is that the challenge of urgent cares is that, but they also make a lot of money for healthcare systems. The truth of the matter is, and so there's just like the ER makes a ton of money. The problem with the people going to the ER is that that money comes at a cost to the healthcare system because it clogs up people getting to the rooms that need them. So hospitals don't necessarily want people to stop coming to their doors. They just want people to go to the right door.
Okay, and then if looking at this map, this is a very helpful map. Out of these, I mean, I know we fund the community health center, CW Williams, et cetera, but out of these, who are our actual partners? Or
Sure.
would you just say that we are funders?
We partner with everybody here, and we have a financial relationship of some sort with everybody other than the 2 hospitals for primary care services.
Okay, so Atrium at Biddle Point, I was there at the dental clinic, which was wonderful, but they told me that their clientele is starting to change.
Yes.
And so I imagine that downstairs is the same way. Will that be moving to another location? Have you heard?
So
Follow patients?
here's my shameless plug for the CRCs. We are hopeful that eventually we will build another dental clinic. We want to expand our capacity to serve in the dental program. As you guys have heard me talk about before, we hope to serve adults eventually. We're obviously purchasing the mobile unit for our school-based program, which will help service kids who can't get to the dentist if we don't do it while they're at school. And so, but we do want to, you've been to the dental clinic, it's a small clinic, right? And so, but it is a huge provider for kids who don't have insurance in this community because there are not a lot of options for dental services for people who don't have insurance. And so kids who are covered by Medicaid, they just have to, it's a matter of getting them to the provider. The kids who don't have Medicaid though are the ones that their teeth end up being very unhealthy by the time they're teenagers. So we hope to expand our dental services, but we'll need to find a new building to do that. And so that it is a part of our CRC strategy to rebuild the dental clinic in one of those. I hope I'm not getting ahead of myself.
One more question.
Yes.
About the 7% of children not being insured. Now, I think some parents, if they don't have insurance, they're just not going to seek out. And they're not going to seek out any treatment or any care. And children, 7% of children not being covered, are we seeing, parents just don't take their children, and how would they know where they can go?
It's a mixed bucket. There are a lot of access points for Medicaid for kids. And so obviously our partners in ESD are the primary partner who gets kids plugged into Medicaid for kids, but also all of our other child serving agencies within the county and Health and Human Services also work to make sure kids are plugged in. So even our school nurses, as you heard me talk about the school nurses doing care management, one of the things they do is make sure if a kid doesn't have insurance, they work to make sure they can get them plugged into insurance as well, if they're eligible, and which in most cases they are. And so, and then there are other cases where the child may not be eligible because some of these people are choosing to be self-insured because either they have the financial resources to cover their cost of healthcare because they're entrepreneurs and they don't have insurance. And so all this is not people who are uninsured because of there are circumstances, some people are choosing to be uninsured because that's how they choose to engage with the healthcare system, and they have financial resources and can pay cash.
Okay, all right, that's it for now. Thank you.
Commissioner Lee?
Let me first thank you, Dr. Washington, for a masterful job. When you talk about healthcare, it's one of the most critical issues in America is healthcare. We know that. And for the poor, it's even worse. Those of us who've had the experience of working through that process understands pretty much what you're saying. One of the things that happen when we talk about insurance, I belong to an organization that paid insurance for families whose children needed it. So many people will pick up this process if it's asked of given groups, what do you want to do? How do you want to do it? In making a contribution to the community. So we were able to insure those children throughout elementary and high school. But once that ended and they were able to go to college or find jobs, then it was left to them. So that's a way that we can support those who need it the most. The other thing is information. How do we get the information out? And I talk about it all the time. Next time you do a map, put where these locations are. You have them on the map, but for some people, visual sites is important. C.W. Williams is on West Boulevard. You see what I'm saying?
Yes, ma'am.
So that means a lot. Not correcting you, please
Oh,
don't
no,
take
no, no.
that.
I was gonna tell you, one resource we have is we have a locator on the health department's webpage. So,
I'm saying on a map that we're giving to the public.
yeah, so there's a, that does exist. So there's a.
Okay, thank you, thank
Ben
you.
has it.
Let's not take up time
Okay, yes.
discussing it, since you're gonna do it.
Yes, ma'am. All done.
And C.W. Williams, I was shocked when you said that they may be going, leaving that site, because that's the birthplace of C.W. Williams, where that building is today.
They're not getting rid of the site, the building, the facility.
That's the site, that's the building for
Yes.
me. Okay, then, but they do have a sign off of 77.
Oh, fine.
Off of 77, I've noticed.
Yes, and they
So
rent
how many
another,
sites do they have?
they have 2 active offices. One does primary care and they have a dental office that's in another location.
I talked to a
That's
young
correct.
lady that used to be with C.W. Williams some years ago, and she went into her own business, not too far from C.W. and was paying $3,000 a month for rent. And that to me was exorbitant for a site. And you're asking to be financed by agencies to help you to deliver these services. So that to me was out of order. And I found that out at a convention. And the young woman had a business here in Charlotte, and we were paying $3,000 a month for rent, not care for the people. The other issue that I have is that we know where the crescent is. We know where the problems are. We know where the economic level of income of our people. And especially for those who are under subcontracts. You see, we contract with people, but then that contractor does another contract with the people to do the work. And they end up making less than $50,000 a year. Talked to a custodian over at Valerie Woodard's just the other day. Subcontractor. I don't know how much we did, but she's only making $13 an hour. That's unacceptable. Talk to the people here at the government center with the city about the subcontract. People working on the 11th floor is making $7.25. And once there was a lot of talk about it, they changed the contractor and the contract, and they got rid of all of the senior Black people working in that program just last year. So they weren't making but $7.25. And as I talked about it, I got no support. I came to meetings down here in 14 with contractors, with the people, and nobody was listening to the people because the subcontractor had already decided. So there needs to be a different method, Mr. Trotman, of working with these subcontractors who get our money and decrease the amount that's available for salary. So that's a major issue. So if we could do that, I went to Presbyterian a couple of months ago. I had to wait 8 hours before I was seen. I waited 8 hours, not 1 hour, not 2 hours, but 8 hours, and I was in excruciating pain. When I fell out here on the back, they could not take me into the hospital because it was the day before the virus. So nobody would take me into the hospital for surgery. All they gave me was pain medicine, and I refused to take that because I didn't want to become addicted to it. And then the other concern I have, Mr. Dunlap, not Mr. Dunlap, but Mr.
Griffin.
Mr. Griffin.
Little Rock Church.
It's got more hair.
The other concern I have is those who are handicapped is a major concern for all of us, because you never know when something's going to happen to you and how you're going to be treated and how you're going to be spoken to. But when I was told there was no support for me to get in and out of this building, that if I got in, I had to come through the front door, couldn't park in the garage. So we need to, and then Mr. The manager of the city, this building, now we have handicap parking. I've been asking for that for 2 years or 3 years. So we have to look beyond just people going to the hospital, but handicapped people also. People will park in a handicap park and can walk and ride and do whatever they want to do. And there are ways in which you can report that, but we have to be more conscious of taking care of our people.
Sorry. Commissioner Lee.
Did I go beyond 3 minutes like other folk?
Yeah, you did. We all went beyond 3 minutes.
Thank you.
I was fair to everyone. So we got one more quick round, but I need your help and advice and direction for us as policymakers. How do we get in front of us some action to first define the gap? Because, we're having this wonderful conversation about what the problems are. I want to be talking about fixing the problems.
Sure.
So how can the commission get the ball rolling to first say, okay, here's the gap, because we all read reports. So what should our next steps be? And I'm talking to my colleagues now. What should our next steps be to get to a point where we can say, okay, here's a gap, whether it's children's access to physical health or adults' physical health or mental health or whatever, here's the gap. And here are some steps. We're not going to resolve it, just like affordable housing. We're not going to do that. So how can you direct us, or do we need to talk among ourselves, the four of us? How do we get to that next point of defining the gap in services?
So I think that's what we are working towards. And I think that is, and I don't want, if you guys want to discuss it, I'll shut up. But I will say from a staff perspective, we are working, that's exactly what we're doing. I mean, we're working towards being able to measure our progress, define where we're headed to, and be able to share with you guys that direction, and also an ask of what we need. And I guess I'm saying I came last year during the budget process specifically asking for more money because we talked to the providers and they all indicated they had capacity to take on more work, right? And so, and then in the last year, we've done that, and it's not even been a year yet since we've given them these enhanced amounts of resources. Ben's overhauling the process, and I expect at the end of the fiscal year to be able to share more details about how much of the gap we've closed. For me, at least, the gap is Are we serving more? I know how many people don't have insurance, right? So my assumption is that at least 75% of those people need primary care access that's not at a paid provider. So I know how many people, I need to figure out exactly how many people we're caring for through the money that we're investing today. I think that number is going to be around 11,000 plus this year. And then we need to incrementally grow that number. It's not going to close the gap completely, but it has to also be in partnership with the other people who are playing in the sandbox. So I think we're working on it, but it's not an overnight thing. So this is not something where you can just say like, oh, well, we fixed primary care access in 6 months, because it is a matter of, if you go back to this particular slide, this is the challenge that we've got as a health department in terms of how we're thinking about this work is I've got to work on the individual behaviors. And we have strategy that's doing that. And that's a slow game, to be very honest. I mean, getting people to change behaviors, particularly men, because for men, it's different than for women in terms of our need to receive routine care or get annual physicals. Most guys, for example, get annual physicals because of they play in sports when they're in high school, but when they transition into adulthood, we don't get pap smears and we don't have that same kind. So it's not ingrained in us necessarily to do that. And this is not me being gender biased here, it's the truth, right? So, and so making sure that we work on this first side, individual behavior, but then we've got to be able to create access points, which we have done to expand. And I think you'll hear more about us proposing to do more in that space to create more access points in a reasonable way. But then also be able to determine what capacity the existing providers have to be able to do more in terms of availability of appointments for people. And then I really have got to, Ben is really focused as well on this whole notion of quality and appropriateness of care, and making sure that we're not getting phone calls at the health department from folks who say, I'm not getting quality care from X provider. So Commissioner Griffin, we talked when you came to the health department, I think I appreciate you guys' support in uplifting this, but there's a lot of staff work that has to happen to be able to start to move the needle here. And so I don't know that there's an ask from you guys today necessarily, other than continue to support us as we have.
I'll say this, and then whatever last comments my colleagues will have. For me, it's what you believe. It's like our school system. There's a school building and there are teachers. So if kids want to learn, they can. If the parents want to participate, they can. I come at it from a different perspective. I think it's a moral obligation to help people improve the quality of life if I can. And therefore I will advocate for improved education from the school system. Now I'm on the county side of the ledger, and you're telling me that majority of people who were premature deaths are African Americans. So I think it's a moral thing for me to say to the public that in these census tracts in this community, African Americans are dying before age 65. And to say that you're not getting your full Social Security because you're dying before the first check gets to you, or your grandparents are leaving you far too soon. I just think if we have some capacity to educate, we ought to try to improve the education piece, then deal with whatever gaps in services there may be through some analytical manner that you can simply reduce some of that. We're not going to eliminate it, but to me, it's about the quality of life for all of our citizens, but particularly those that we know are suffering to some capacity. And that's all I'm going to say. And I just hope y'all help me. And I apologize to colleagues, Commissioner Powell, then after Commissioner Powell, Commissioner Meyer, and then Commissioner Leak in that order. And then we'll close this thing out. Commissioner Powell.
Thank you. It is complex because there's so many things that impact health. And so not only does individual behavior matter, but then access to care and access to healthy food.
Words out of my mouth.
Access to places to play and recreate. It all is connected. And so how do we provide the best opportunities for the people in Mecklenburg County? And how do we make sure, like, after we know what the gaps are, how do we make sure that the burden isn't totally on the county, that we share the burden with community partners and people that have come in here and are making so much money on Mecklenburg County residents that they have a duty, in my view, to the community to be a very strong, faithful partner, to step up. And I don't feel like the people who should be stepping up are stepping up the way they should. So, I mean, I think we need to be about making things better, but also making sure that we work beyond the government with partners.
All right, Commissioner Meyer.
I really don't have a question. I just want to say that when I first came on board, we didn't talk that much about primary care, and now it's just one of the main things we're talking about. So the attention that we're spending on it, that you're spending on it, and your staff, you're doing a tremendous job. And I think there's only one way up. I mean, there's only one way, and it's up. I mean, I really do think that. I think you're heading in the right direction, and you've got our support, obviously. So thank you.
Commissioner Lee.
Let me again thank you for your work and your staff. Budget is important. People refuse to vote for a budget, but yet live off the budget, travel off the budget. So there must be some concern. When you support a budget, you support the people. So my concern is that we need to educate, as was stated by our chairperson, Mr.
Griffith.
Your colleague over there. All right,
But
Commissioner.
anyway, my concern is educating the community. But the major problem is a national problem. It's not just a local problem. It's a national. And as we grow, people still coming in to Charlotte, Mecklenburg with problems. Because the violence that we're experiencing now, we've never experienced before to this degree. So we keep growing without the support of people who come here prepared to make a contribution to this community other than to take from the community. So you have my support, young man. You've always had it. So thank you for your work, and your staff and the staff members who are here. Thank you for what you do.
We are at end of our agenda. Thank you for, as all of it we've indicated, I'll reach out to Mr. Trotman
All right.
for any
More education.
follow-up comments before I ask for a motion to adjourn. Mr. Trotman, do you have any follow-ups?
Well, first, I want to thank the board for your investment in primary care and access to care last year. In all areas of social determinants, because it definitely is not just the doctor visit, it's what you eat and the air you breathe, the transportation routes, access to affordable housing, decrease in violence, all the different things that contribute to a healthy living, you all are invested in on an annual basis. And I want to say how much I appreciate you for your leadership, not just at budget time, but when you make your priorities, you have consistently made this a priority. And so I'm looking forward to Thursday when the manager releases her budget to you all, as she has heard you and your priorities, and I'm hopeful that you will be pleased. I know you will be pleased with her presentation.
Have you seen it?
Anyway, Chair would certainly entertain a motion that we adjourn.
So moved.
All right, the second.
Second.
Okay, all those in favor, just say aye.
Aye.
All right, thank y'all so much. Thank you very much.
Thank you.
Thank you, guys.
They should do this.
It's all right. I will be bringing it back to you. Help and support. I didn't do it.
Well, I know Adrian was over.
I'm going to do a
in
half
Valley.
an hour of meeting at 3:30.
It is the city of Richmond. You're from Richmond?
It's a little-
Two urban areas.
Yeah.
One person.
I don't know.
I mean, he has high needs. I haven't had an update since last. I was like,
Give you the answer.
yes, but.
Thank you.